Okay. All right. Well, let's get going. I think it's 9:40, 10:40 Eastern. Good morning and welcome to the Palliative Care Friday Chalk Talk. My name's Sarah Peppers. I'm a palliative care nurse practitioner embedded in the Advanced Heart Failure Clinic at St. Luke's Medical Center in Milwaukee. Is ECMO and Palliative Care. Our guests are co-authors of the paper Top 10 Tips Palliative Care Clinicians Should Know About Working with Adults Receiving ECMO from the Journal of Palliative Care Medicine. Dr. Astrid Gruels completed her residency and palliative fellowship training throughout the Texas now works at Baylor College of Medicine in Houston as an assistant professor. Her clinical and research focuses are on palliative care integration in the critical line, especially ECMO, and in the ALS population. And Dr. Krista Dobby has been a palliative medicine physician for 21 years, primarily inpatient at Cleveland Clinic, but founded their first outpatient palliative heart failure clinic in 2015. Her specialty is heart failure, mechanical circulatory support, ECMO, and lung transplant. Dr. Dobby's palliative care medicine to non-oncologic patients. As for the format of today's show, we'll start with a short review of some ECMO basics, and then we'll have an interview format of discussion with our guests. And for our audience, you will have a chance to ask questions at the end of our time together, and you can always enter questions into the chat as we go. So we'll start with a short ECMO education review with Dr. Dobby.
Hi, everybody. Thank you for asking me to be here. I'm really excited. What I wanted to do is do a very, very brief overview of ECMO. So if anyone out there is thinking about bringing palliative care to this patient population, but you're fearful of what this advanced form of life support is, I just want to give you a very brief overview so you understand what we're discussing. So Marty, with that, so when we talk about an ECMO circuit, there are three basic components to that circuit. We talk about the blood pump, and what that pump does is it actually pulls blood out of the body from the venous side and circulates it through our oxygenator. And our oxygenator is that triangle-shaped diagram part. The oxygenator has a permeable membrane where we input oxygen and it exchanges gas. So we actually add oxygen to the blood. And at the same time, we're able to scrub out the carbon dioxide. And then the other part of the circuit that we always refer to are the cannulas. These are very large tubes, about 28 French. To give you an estimate, like a Foley catheter is about 11 French. So these are very big tubes, and they are actually sewn in surgically, and they are our conduits to transport blood. So here's at Cleveland Clinic. This is what actually it looks like. So you can see the little triangle-shaped device. That's our oxygenator. And you can see the oxygen tank with inputs. The round device up to the right is actually the Rotaflow, the small pump. Next, we're going to talk about the blender or sweep. So what we do with that oxygenator is we can input how much FiO2, what percentage of oxygen we want to flow into the oxygenator, depending on how hypoxic a patient is. And the sweep is the little gauge off there to the left where you see liters per minute. And so by what you need to know in palliative care, these are just the nuts and bolts. A higher sweep means the patient is doing poorly. So when the lungs aren't working, we have to scrub out more CO2. So when you see sweeps of 8, 9, or 10, those are severely damaged lungs, and we are compensating by pulling out more carbon dioxide. So one of the things I always ask when I go to the bedside is, what is our sweep? And have we been able to wean that down at all? And that will give you a kind of an indicator of how well somebody's doing. Okay. So let's just talk very quickly about indications for ECMO. There are two types of ECMO, and these are based on how the cannulas are placed or how those tubes are where they're put in the body. So VV ECMO, I just wanted you to think of VV ECMO as kind of bypass for the lungs only. So that is respiratory support in patients that are not doing well. And we usually have, what we have for VV ECMO is venous to venous cannulation. I'm going to show you a picture of what that means. Basically, we're taking blood out of the venous side and we're putting it back into a vein. And so it's okay, Marty. So our indications are for acute hypoxic respiratory failure like ARDS, or patients that are having hypercapnic respiratory failure where they failed mechanical ventilation. And most importantly, where you'll see VV ECMO, I think, is in patients that we're trying to get to lung transplant, because in pulmonary fibrosis, we may have them on VV ECMO while they're waiting for lungs. Okay, next slide, please. So let's talk about the cannulation. So VV ECMO is most common cannulation is the femoral vein in one leg to the femoral vein in the opposite leg. And let's just go right to the picture. So what you'll see here is the femoral vein, the blue being the blood in the venous side, and going through the pump and the oxygenator. And when it goes to the femoral vein on the opposite leg, we're actually putting that catheter up very high. So the idea is you want that oxygenated blood really going almost directly into the right atrium. And what happens, the heart is good. So in VV ECMO, remember your heart is fine. And the heart pumps that oxygenated blood now back through the lungs that aren't working and out to the aorta. So that's how VV ECMO works in 30 seconds or less. So let's talk about VA ECMO. VA ECMO is specifically, I like to think of it as more cardiac support. So these are patients that the heart has gone down, and you may or may not have an oxygenator with these patients. Oftentimes with cardiogenic shock, there's pulmonary edema and you're not oxygenating. So you may have an oxygenator as well. So in VA ECMO, we are basically cannulating from the venous side into an artery. And so our indications for VA ECMO are cardiogenic shock, usually refractory cardiogenic shock. These are patients that are on inotropic support and may have already mechanical circulatory support, including like an Impella or a balloon pump, or patients that have refractory cardiac arrest. And these are usually in-house arrests, where we will then cannulate and place patients on VA ECMO. Obviously, another big indication for VA ECMO is for patients awaiting heart transplant. So in VA ECMO, we're going from usually the same side. So the most common strategy is the femoral vein, and then we're returning on the same leg to the femoral artery. So it's two separate cannulas. And we can go to the next slide. You can see a picture. And so what I want you to pay attention to is the arterial side. We're going back in that femoral artery, and we're placing that catheter way up high, up to the heart, into the aorta. And that's important because we have to get blood flow back to our coronary arteries to help preserve our myocardium. So just a brief overview then of how these cannulas are placed and what we're talking about. I wanted to give you guys very quick pearls. And so even if you don't understand ECMO, what is bad if you get called for a palliative medicine consultation? So sweep at the highest level, unable to be weaned. That's a harbinger of somebody who isn't doing well, that may now be stuck on a technology that's not going to be able to heal their lungs. Hypoxemia despite high flows and high FiO2s. Clotted oxygenators are oxygenators with a PaO2 of less than 200. So I always refer to the oxygenator change as the NASCAR pit stop of critical care, because every time you change out an oxygenator, that person is not getting oxygenated blood that's circulating. This is a very critical time because patients can arrest and often do arrest during oxygenator changes. And anytime that PaO2 is less than 200, we have to change out that oxygenator. So nurses draw blood gas right off the oxygenator. So you can say, how's the oxygenator? And the nurse can tell you if it's bad, clotted, what the PaO2 is. So obviously, the more times we have to change it, the more risk to the patient. And that's an indicator that we also probably have some type of clotting disorder that's developed as a complication of ECMO. So in VA ECMO, where we're using it for cardiac support, if we're unable to wean the flow, that's an indication that we don't have cardiac recovery, because as the heart recovers and is pumping more of the blood by itself, we can turn down the flow on our VA ECMO. And if we're not able to do that, that's a bad sign. Anytime you see VV ECMO, remember, VV is just respiratory support. However, in pulmonary fibrosis patients and patients that have pulmonary hypertension, unfortunately, if they develop right-sided heart failure, you may see the cannula strategy changed and VV ECMO is changed to VA ECMO. Again, that's a very poor sign in somebody who may be trying to get to lung transplant. Anybody that's having multiple ECMO clinical complications like bleeding, clotting, developing DIC, those are going to be patients that you're going to want to keep on your radar more closely. Anytime you have development of multisystem organ failure, I mean, this is much like a ventilated patient at this point, because as organ systems go down, their overall rate of recovery obviously is going to be less. And then we talk about no exit strategy in ECMO. And what we mean by this is all of this technology is used with the intention of temporary support in order to help a patient recover. But if we have a patient who is not a transplant candidate or becomes so sick that now they cannot be transplanted, we have them now on a technology with what we call no exit strategy. So these devices are used to bridge patients to recovery or bridge to transplant. And when we talk about not being able to bridge them then to a more permanent solution, we talk about a bridge to nowhere patient. And Astrid and I are going to talk about how do we help families when patients are now on a life support with no exit strategy.
Well, thank you so much for that review. I think that last slide was especially helpful, reminding like these are the bad signs. So for our interview portion, in your article, you discuss how ideally palliative care should be involved from initiation of ECMO to decannulation and beyond. However, we might not be involved until well into an ECMO run. What do you think is the palliative care role when consulted early in the ECMO process and end of life is more imminent?
Yeah, I could take that one. First of all, thank you guys for having us here. So I think palliative care's role, as I think you can pick up from what Krista kind of started us off with, really changes throughout the course of somebody's time on ECMO. I'm really thinking about people who are on ECMO for a period of weeks. So I think of this as kind of three phases. Early on, if we get that consult right after cannulation, our role may be education, helping to set expectations and supporting the team in having those initial conversations to be very clear that this is life support and it's intended to be temporary. In that middle period, we may primarily play a supportive role, especially if the patient is intubated and sedated. We may be one of the most consistent forms of support for the families, because we find that the ECMO team changes frequently. It's a big team. And then as we move to the end of somebody's run on ECMO, we always hope that that's a period of survivorship. And so we may be working with patients as they're waking up or kind of helping think through that survivorship process. Or we may be facilitating end of life conversations and talking about ECMO withdrawal. So it really changes over time.
mentioned that the team that we're involved in and helping can be very large. We've got often intensivists, CV surgeons, all sorts of supporting teams. How do you think that palliative care can best interact with the rest of the ECMO team, including surgeons, intensivists? What do those teams expect from palliative care involvement with these patients?
I get asked all the time, how do you interact with your cardiac surgeons? And I think the one piece of advice I'd like to give everybody is that I want you to all believe that you add significant value when you come in as the palliative care provider, because you do. My surgeons always say, I'm not good at talking to families, just like I wouldn't be good at putting in an LVAD, you know? So I think, number one, believe that you have so much to bring to these patients, because you do. And I think what's helped us here at the Cleveland Clinic, what you may want to think of a strategy is to have a dedicated team member from your team that wants to see these patients, wants to learn about these patients and become dedicated. Because what this does is this helps build like rapport and trust, so your cardiac team knows who to call. If you don't have a really robust team, and you can't do that, I think there's other ways that you can just be available. And one of those ways are attending multidisciplinary rounds. Even if you can't go, I don't go every day, but even if you go one day a week on ECMO patients just to get the clinical update and be seen, and attending multidisciplinary meetings. I try to attend the medical updates, even when we're not making goals of care decisions, because that's another time to interact with the surgical team and the intensivist team. So our involvement grew out of a lot of the palliative care teams are already seeing the LVAD patients as part of JCO requirements. And then we became more integrated in our cardiovascular ICUs. And I'm really proud of the fact that any patient on VV ECMO here at the Cleveland Clinic gets an automatic palliative care referral. And I'm even seeing, there's kind of like a ripple effect. I'm even seeing patients on VA ECMO now, we get called earlier when we're concerned that there may not be cardiac recovery. So I think, you know, having a dedicated person, attending rounds, really believing that the team wants you there, because they do.
Yeah, I think in the past, when we were talking about this too, you mentioned that we're here to share the burden in situations like this. And I mentioned that to a CV surgeon I was working with recently, and he's like, that is great. That is what you guys do. We really do appreciate that when it comes to the communication with these very long-term patients. Because ECMO, you know, it really can consume substances. It's very labor intensive, both physically and mentally, for everyone involved. We're often in it for the long haul, especially those VV patients can be on it for months. How can the palliative care team remain involved in the care of long-term ECMO patients, but not overly burden themselves due to their own high patient census for palliative?
That's a great point, Sarah. And I think I could speak to that. We have a very small team here at Baylor St. Luke, small but mighty, I call it. And you know, you're right in that the number of ECMO patients can really stack up. When we're kind of in that middle period, referring back to kind of where we are in the ECMO journey, we may be involved with once a week visits, checking in for support. The patients and families have our phone number, so if something comes up or they need someone to talk to, they know how to reach us if we're missing something. All the teams know how to reach us as well if something comes up in between those once a week visits. And then just as Krista was saying, I think being involved in those multidisciplinary meetings to stay abreast of everything that's going on is very important, and in my experience has been manageable with a relatively small team as the only provider here who's been dedicated to ECMO consults.
Yeah, what we do here at Cleveland is we also have a social worker on our team, and I really want to highlight social workers because I'm one of the biggest fans of social work support. And we have our social worker, if patients are here very long term, we will leave them on our list. I will touch base with the intensivist day to day, just saying, how's the patient doing? Where are we headed? We're still in a holding pattern. But I will have our social worker actually just call the family, even if it's just once a week, check-ins. How are you doing? And that's kind of how we share the burden of keeping a patient on our list for maybe several months. And it actually is quite nice because oftentimes these patients crash unexpectedly. And Astrid and I made a point in our article to say that sometimes the palliative care team is the only continuity because the intensivist teams have changed so much. And the social worker can really be the glue that holds the family together when we need to sit down for those really difficult discussions.
Yeah, always want to give good shout out to the social workers. I always say they make the world go round. Where would we be without social workers, you know? So tell us about how palliative care involvement can be different for patients who are, you know, traditionally what we think of on ECMO, sedated, intubated, paralyzed, versus patients who actually are on ECMO for quite a long time and are extubated, talking, alert. What's that like?
Yeah, absolutely. I think it's when I first started seeing ECMO patients, I was really amazed at how over time, a number of patients could become very interactive, communicate, really be very clear about their wishes and become more involved in their care. When patients are sedated, paralyzed, our role may be primarily education or working with the families more so, right? And then as patients wake up, as patients are put on trach, vent, and can start to communicate, sometimes my role also is to help start to integrate the patient into important conversations about where is this going and our goals of care if needed. And that's also more so when I might be involved in symptom management as well, as patients get off of those drips and are waking up. Krista, what's your experience?
I agree with you totally. I think when patients are alert and awake, I think we're doing a more symptom management for those patients, any pain, anxiety management, a lot of anxiety for these patients because they are still feel pretty dyspneic despite being oxygenated well. I think when they're intubated and sedated, again, I think it's more of a family support at that point rather than direct patient support. And again, I think just realizing that the needs over time change for these patients and kind of being flexible with how you're approaching these patients based on their clinical condition.
Great, thanks for speaking to that. It's not often we see these patients awake and alert and talking, but it can happen for some of them. In your article, your final tip was to address both emotional distress of the family and the medical team. In what ways have you seen moral distress in the care of ECMO patients, and how do we help with that?
Astrid, I'll go ahead and start, and then you can add your 2 cents and what you think. I think ECMO creates a significant amount of moral and ethical distress because, again, we use these technologies with the best intentions. However, when we have young people that can't get to transplant, that are awake and alert, and we know that they are now a bridge to nowhere patient, and at some point we're going to have to turn that technology off. That is very distressing to our clinical staff, our nurses who are at the bedside, to the families. And so I think as palliative care providers, what we can do is support. Sometimes the palliative care consult is actually the support goes more to the caregiver team. And I think the way that we help our surgical staff and our intensivists is by having that long-term relationship because we followed that patient. It's horribly distressing if you are an attending coming on and you've never met the family and you have to talk about withdrawal of technology. So I think we support the staff by being continuity. Also, I think we're great at reframing medical jargon into plain and simple language. And we can also deliver that message more clearly sometimes than our surgical staff. Also, I think sometimes our staff relies on us to provide that second medical opinion, to back them up and to say, you know, what Dr. So-and-so is saying is absolutely correct. And here's why. You know, we have multisystem organ failure now. What does that mean? And I think they look to us. One thing that I really like to say when we're talking about stopping these devices is we talk about all the ways we haven't been able to get somebody well. And so what I like to do in those meetings for my team is to reframe that and say, let's talk now about what we can do for your loved one. And what we can do is provide dignity and comfort and allow them to die peacefully. And so our team really looks to our intensivist team really looks to us to explain that to families and talk about how that deactivation is going to look. And I think that that also takes the burden off of them. And I think there's such value in that. And I think it's a privilege to be there at the bedside with a family when we are unable to cure them.
Absolutely. I want to echo what you said, Krista, about kind of shouldering that burden, because, you know, we are able through that continuity to develop rapport with the patient if they're awake, and the family, and have that longitudinal relationship that sometimes our intensivist staff isn't able to build because of just how their scheduling works. Sometimes kind of coming from a different perspective, sometimes I think my role as a palliative care provider is also to reframe the situation when patients and families are insisting on a little bit more time on an ECMO device, reframing that for the providers that are having distress with that request, and getting to the root of why that request is being made can be really helpful for their understanding. Because oftentimes, you know, as you explore that request, there's a particular reason for it. Perhaps they're waiting for someone to visit before changes are made, or you name it. And I think our team can be helpful at kind of teasing that out as well.
That's also helpful. I think some really insightful points there. Thank you guys. I think we're coming about to the end of our moments together. Marty, is there a couple questions in the chat we might still have a minute for?
Quite a few comments. Tracy points out that she really, I think, appreciates how often we are the constant for families and how important and how valuable that is. One question that came in was any advice or pointers for how you approach ECMO discontinuation from a symptom management standpoint? Is it a correct assumption that we're approaching it similarly to an LVAD discontinuation, where you sort of lose circulatory flow and you have a pretty narrow window to make sure these patients' symptoms are well controlled?
Yeah, I can take that question. Yes, it's very similar to an LVAD deactivation. You want to give all of your medications well ahead of time and give them time to circulate and work before you deactivate. With a ECMO deactivation, death usually occurs within minutes. I have had LVAD patients survive much longer. And so I just like to ensure that we give enough medication to make sure they're comfortable. We do not remove cannulas. I know some centers do deactivation in the OR. We leave our cannulas in place and just clamp those. And I think the most important thing is just to pre-medicate early and give time for the medications to circulate before you deactivate the device. Astrid, do you want to add anything?
Sure. I'd say that in my experience, the doses of of your opioids or your anxiolytics may be a little bit higher, even than we are used to as palliative care providers. There's actually a great article on this, because there's a lot of great points that could be touched on. It's called Finishing Well. I can put a link to it in the chat, by Dr. Machado et al. And it has a great checklist to think through if you are asked for the first time to participate in an ECMO withdrawal. So.
Can I add just one more quick follow-up question? Do you notice a difference between your approaches to symptom management between VV and VA ECMO? Like, is VV a little more similar to terminal extubation because there may be more intrinsic cardiac function and more flow, and maybe it takes longer?
Astrid, do you want to take that one to start, or do you want me to take that one?
I'll let you start.
I have not seen a big difference personally. What again, and I echo exactly what Astrid said, you want to use bigger doses than you might normally think you need, but both devices, patients are so critically ill. I have not seen a difference when I deactivate VV versus VA personally.
Same. Yep.
Right.
Well, thank
Well,
you.
thank you. Yeah, thank you, Dr. Dobby and Dr. Groves, for taking the time to be with us today. I learned a lot from our conversation. I hope everyone else did too, and we hope that you have a good weekend.
Thank you
Hope we
guys so
cross
much.
paths again.
Thank you so much.
Thanks. Bye.